Welcome back, everyone, to Four Eyes, the podcast series that gives you a clear view into the optometry world across Canada and the US. And we are back with another new grad case reflection. Today, it's Alex's turn. So, Alex, why don't you kick it off?
Well, I saw this patient about a month ago, and it's a 50-year-old white male. Last eye exam was with us in October of 2020. So the complaint came in as an emergency. Complaint is about 6 or 7 days ago, I noticed that my distance vision was very blurry. The way that I am able to see my computer screen, which is about 3 feet away, is I tilt my head back and look through the low portion of the progressive lens. The blurred vision came on gradually over the past week, and one day I just noticed it was extremely difficult to see in both eyes. It is as if my glasses were upside down. Everything else is pretty normal, with my vision is just blurry. There's no pain, irritation, headaches. The vision today is even more blurry than it was yesterday. And then his last checkup was with a PCP about 10 months ago. Medical history: he has high blood pressure and seasonal allergies. Versions were unrestricted smooth. CVF was full fields. IOPs were 15, 13, and pupils were 5/3 with no APD. So the glass is verified at -4.25, -3 axis 75, has a little bit of an add of +175. The other eye, the left eye, is -5.25, -250, axis 125. So the best vision, that we got for distance, was 20/40 -1 for the right eye, and then 20/30 -1 for the left eye.
Is all this information so far just what your technicians and your scribe does before you see the patient?
It is, yep.
Okay.
Some of the chief complaint is what I asked as well, and so it kind of is all linked together. But
I was gonna say, dang, your scribe is really thorough.
No, I mean, no, she is, but she is thorough. But like a lot of it was me asking questions too.
Gotcha. Okay.
Yeah. So then the glasses verified, best corrected with both eyes was 20/30 -1.
Okay.
And I repeated. So the refraction that was done in 10/20/20 basically reflected that being accurate, his prescription. And he could see 20/20 plus in the right eye and 20/15 in the left eye. Both eyes he could see 20/15.
How old is this patient again?
50-year-old white male.
Oh, okay.
What are some questions that you guys would have asked at this point?
What are his autos like?
I don't have that information in front of me, but that is a good question.
When he's looking, it was like suddenly became blurry for him when he was looking at his computer, and then he tilted his head back and it became a little bit more better.
Tilted his glasses up.
He tilted his head, so he's looking through
more
hyperopic.
Hyperopic.
He's getting this gradual hyperopic shift.
But it happened over a week and a day.
A week.
Are there any questions though that you guys would ask the patient on top of?
Any recent stress?
Yeah.
That's one of the questions I asked. I asked, have you had an increase in stress over the last 5 months, just because, that time that we haven't seen him? And he said, yes, since August, he's had multiple causes. He's going through a divorce and he's adjusting to single life.
Oh,
it's up in here.
Yeah, Alex should have been like, that's no stress. Boy, you are stress-free now.
Yeah. Well, so a few other questions I asked. I said, is there any recent illness or change in medications?
Yeah. Or even trauma or anything, like hitting the head or something?
People are coming wearing masks, right? And so it's hard to see. Head, there was no trauma, but it's hard to see anything around his mouth. He said a week and a half ago, he went to urgent care and the PA actually drained an infection that was on his upper lip.
Oh,
whole face was swollen, but he says today it's 90% better. And he was on an antibiotic and it took a little bit for that to kick in, but he hasn't recalled any vision shift. He doesn't think it's due to that, basically.
Okay.
That happened 1 month ago.
No, it happened a week and a half ago. So around the same time that actually started changing vision, right?
Yeah.
But he doesn't think it's linked. But I also asked if there's any type of steroid use. So, are you taking steroids or working out at the gym, that kind of thing. And he said no history of any steroids. And then I also asked, does your vision fluctuate throughout the day? Do your eyes feel watery, gritty, or dry throughout the day? He says occasionally, but not really too much, basically. And then I also asked, did you have blood work done at your PCP at your last visit? And he said he thinks he did. He said that his PCP basically told me his high blood pressure and his blood sugar was fine, he thought.
Oh, okay.
So are there any differential diagnoses so far?
It's hard to, sometimes I feel like with patients like this with gradual decreased vision, sometimes I don't even go through the differentials in my mind because I'm just like, you know what? If the glasses aren't fixing you, we gonna dilate. We're gonna just see what's back there and then figure it out that way.
Yeah.
So I feel like
I'm not even like thinking, I guess that's like me too. I don't even think about differentials. If they're like, if there's any issues with vision or if their vision, I can't get them to like 20/20 or something like that, then I'm like, all right, what's going on at the back of the eye, especially with his age. I'd be like, all right, dilate.
Yeah, because
I need to mentally think. I need to mentally prepare myself for something like worse. So I go through my differentials. I'm like, what
Good
is this? What
Good for you, Rav. Me and
What if
Amber
I
are
need
just
to
like,
call
no
emergency.
Well, and I think a benefit of like our practice is I get to see a lot of info before I see the patient. So as they're working them up, I can see what's happening and be like, okay, what do I think is happening? Especially with emergency patients. It's nice.
Well, I guess you could say, okay, I changed my answer. So when I get that information, I'm not thinking of specific differential diagnoses, but I'm already thinking it's most likely something like posterior seg. Like in that, in my mind, it's not like, okay, your refraction is still, not that great or your vision didn't really improve. Now we're going to figure out it's something retinal or it's something, in the back of the eye. That's my differential.
Okay. Well, so I haven't. So
Alex
I basically did.
Nothing was wrong in the back of the eye. Now what?
Well, no. So I repeated the refraction.
Okay.
His refraction. So at the last visit, like I said, it was -4.25.
Yeah.
That day it was -250.
Hyperopic shift. Okay.
That's huge.
And then he was -5.25, and that day he was -375. So, yep, hyperopic shift for the right eye was +175. For the left eye was +150.
And he got down to 20/20, right?
20/20, 20/15, and then 20/15 with both eyes. Yep.
He said he had swelling in the face
on his lip.
He didn't. So not around the eyes though.
But I'm wondering, like, is there some internal swelling now, like behind the eye?
Happening.
He said no headaches or no. CBF was fine, but obviously, I'm sure your text did not do a Humphrey visual field.
Well, I do the CVF, so I did.
Okay.
So I guess some of that info was me. So I do the CVF, I do the versions, and then pupils.
Okay.
So.
And it's all clear. Yeah.
Yep. All that was clear. Anterior segment was unremarkable, except for there's decreased tear meniscus, and he had a little bit of cataracts, but they've been stable for about 3 years. So while the patient was dilating, I ran an OCT wellness just to check at, if it is CSR. Then I just wanted to have that just while he was dilating because just cleared up some time basically. With the wellness, we don't charge though, and so he wasn't going to get charged for it.
What is OCT wellness?
It takes a general, it takes a scan of the macula, but it's not as in depth basically. But you can see all the layers and at least
so it's like it gives you like a general idea of what's going on with the macula, so you have a general idea of what's happening there, which is good. Yeah.
And so posterior segment was actually stable. There was no hypertensive retinopathy, no diabetic retinopathy.
Look at
There's
Rav's
history
face.
of
He's like,
lattice.
I was like so sure. I'm like, oh my god, it's CSR. I'm 100% sure.
I know. That's what I
Rav, see,
thought.
this is what happens when you try to
I
prepare
know.
beforehand.
don't prepare.
Me and
Don't
Amber
make
just
it
go
for
in there
yourself.
not knowing anything, not mentally prepared
Always
for
blind,
anything.
Rav.
Yeah, I feel like this would
Confident.
stress me out more.
Yeah.
I'm like, oh my god, I don't know what to
Yeah.
do now.
Well, and part of it though was I was able to correct him to 20/20. With CSR, you can't get him to 20/20, but I just wanted to check and make sure maybe it's like the start of it, or something like that's happening. But I had the same idea, Rav. That's what I was like banking on, was that he sounds like the typical white male, stressed out. Sounds like it, right? So at that point, I asked the patient if he's had any other health changes that we haven't discussed yet, any weight loss, weight gain in the last 6 months. Patient reported losing 40 pounds in the last 5 months with just a slight adjustment in portion size. And so like he has alcohol every day now, and he's like, could that basically become an issue? And we kind of talked about how it would have to be a lot more in long term, basically. So at this point, my tentative diagnosis is diabetes, because you can have large weight drop gains and weight losses. And so what I recommend to the patient is in the next 2 weeks, go have a checkup, get blood work done. We'll send the chart to the PCP. And then I told them, do not get new glasses right now. Just try to find an older pair, and we'll see you back in about 2 weeks.
For the blood work, did you decide on which specific test you wanted, or?
I want A1C checked.
Okay.
Yeah. And then also just a normal blood sugar draw too, because we basically sent the info over to the PCP. We don't send the blood work itself to the lab, but we kind of just sent a letter to them basically explaining what we thought is happening. And this is what's happening with the eye, basically.
Yeah.
Okay.
And you said this was unintentional weight loss?
Yeah. He basically said, I mean, he's changed slightly in the portions.
Yeah.
But he's having pizza still. He's having like not very healthy food.
Not
but yet
5
he's having,
pizzas, just one pizza.
Not
Yeah.
home cooked meals anymore.
Not quick. Yeah.
I
And
was
so,
gonna say, I reduced my portion size. I didn't lose 40 pounds. That was
yeah. Yeah.
So much
I mean,
easier
that's
for men to lose weight, though, I feel like, compared to
yeah.
women.
women. Yeah.
Yeah. So I did see him back 2 weeks later. He basically says that he's wearing prescription from 2018. They are a weaker prescription, so he can see is slightly better. The refraction that day, instead of the 2.25, it was a -3, and then he was a -450. So he's kind of creeping back up to what he was back at, in September. And his vision really didn't change much over time either. The last 5 years has been pretty steady, like maybe a click change here and there. So our plan is to see him. I think I see him actually next week, and he's gonna, after that, he would have seen his PCP at that point.
Okay, so we didn't get the report back yet for his blood sugar.
No.
Man, that is so crazy, because I thought CSR as well. Like, he's going through a stressful time. Even like, I guess if his VAs were not improved, I would also maybe think of like non-organic visual loss. Like, when people just kind of go through stress and they just, their fields constrict, and they kind of, it's like a non-malingering syndrome. Right? So yeah, that's crazy.
Yeah.
I was also thinking maybe it was just a really bad, I was thinking like the lens, something that could
Maybe
be
he's
going
just
on
really
with the
over
lens.
minus.
He was fine for 5 months though. He could see, and then all of a sudden a week and a half, 7 days or 7-8 days, he can't see as well.
Yeah.
So
And there was like no bleeding, nothing in the back of the eye,
no.
I feel like this has to really be related to the significant weight loss. Like, I don't know why. I just feel like if you lose that much weight that fast, maybe that's affecting your prescription. Since
That's almost like 8 pounds a month.
Yeah. No, it's significant. That's a lot of weight.
Yeah.
How much?
And he hadn't seen his PCP.
Is he like overweight right now still, or is he like?
he didn't look overweight. He looked, like just average. You
Okay.
wouldn't think that he had lost 50 pounds either, though.
Okay.
Kind of thing.
Okay. Because I was thinking if you're like more overweight, then it's easier to lose that much weight in a shorter
Right.
amount of time. But if he's already average weight, then it's still significant.
Yeah.
So
I guess the lessons learned were don't assume. Because when you assume,
otherwise you make an ass out of
you and me.
I mean, yeah, I feel like if I sat down and thought
That
about
quick.
it with that much of a change, I'd be like, maybe it is diabetes, but then I would just feel so confused about the posterior sag. I'd be like, why isn't there any signs of
Maybe
It
there's
would
like
be.
minimal increase in like the NS, which from the naked eye, like you can't tell the difference, but
Mhm.
it's enough to cause that big of a change in the hyperopia.
Yeah, maybe
Yeah.
some cataract changes that are just not visible to the naked eye. I agree.
Yeah. I mean, that definitely could play a factor, but the fact that he kind of went more nearsighted again, though.
that's what's not make because it's like
Afterwards.
fluctuating vision, right? So that's why it's
Yeah.
like, oh, what Alex was saying, like it's probably some sort of vascular issue or diabetes. Because if it was the lens, then he would have been going one way
Mhm.
the
Right.
entire time
Yeah, 'cause
and
it's-
I
not
wonder if it like,
back and forth.
what about like some sort of like corneal edema?
Right. His
Can
cornea
you
was clear, though.
have cornea?
I
Can
mean-
you have like edema from high blood sugar?
Probably.
Because then, I mean, if you think about it systemically, if you lose so much weight, it probably is affecting your water channels to some extent.
Yeah, that's a really good point. See, but again,
Yeah.
I think it kind of goes back to like I think the same way. I think the weight loss, the significant weight loss has changed some structure in the eye, regardless of if the weight loss is related to diabetes or not. But I think in general, if someone loses that much weight that fast, even if it was intentional, I think they would go through significant vision changes. That'll be interesting for any of our listeners to also let us know if they have any patients that they've experienced with significant weight loss who have had vision changes and maybe it wasn't even related to any structural damage to the eye. That would be really interesting to know too.
Yeah.
Good job,
And then
Alex.
wait, Alex, when do you find out what happens with this?
I think I see him either this week or next week. I know it's coming up.
Ooh.
Like I said, I'm on the schedule. So I'll know here soon, hopefully.
What if his A1C is normal?
You know?
You know what? We're gonna cross that bridge when it
Yeah. I would probably say he needs to get an MRI
Mm-hmm.
because it could be
Yeah.
tumor related.
Yep.
So I mean, you don't hope somebody has diabetes, but I'm hoping it's more related to that than it is a tumor.
Something
because
else.
But for anyone listening, if you guys have any differential diagnoses or different thoughts going through your head or different tests you would have done, feel free to go on our Instagram for this IGTV and comment there, or comment on our post on Instagram that'll be related to the episode, or DM us or tag us in stories. Let us know because it'll be really interesting to know everyone else's thought process when they're going through in a weird case like this, where really right now there's no completion to this case. So yeah, let us know.
Which is like a lot of cases that we probably go through a lot of the times, especially if we refer off to someone else and we're like, I wonder what happened to that patient.
Yeah.
So we decided to come back and record the ending of this episode because when we first talked about Alex's case, she was still waiting on the results from the family physician from getting the blood work done. So now we finally have the results back. And Alex, do you mind telling us what it is? Drum roll, please.
it was diabetes.
Woo!
We
He-
guessed it.
We guessed it.
Yes. His
So-
A1C was 9.2.
9?
9.2.
Okay.
Yeah.
And that's not
So-
that's not
Yeah.
too high for him. Like that definitely could have gone missed if he didn't come in for his eye exam.
Well, he came in as an emergency. It wasn't even a normal eye exam. He came in because his glasses, he's like, I can see better in the lower portion than the upper portion now at distance. So
yeah. But you said his retina looked healthy though.
Yeah, there's
like his macula wasn't swollen. His retina wasn't like, there's no bleeding, no retinopathy that you could see.
Right.
I'm curious to know, how did he get a hyperopic shift then if there's no I would still assume that swelling would have caused the hyperopic shift, like from diabetic retinopathy and macular edema. Are you going to have him back for follow-up then? Like, would you do any other testing then now that he's diabetic to see where the shift, like?
Well, I did the dilated exam already the first day he came in. And then I've seen him back now 3 times total in the last 6 weeks. So I probably will see him back for his annual unless he's having any more issues.
Did his refractive error change again now that he's starting treatment?
It was very close to what it was the last time I did a refraction on him. So it still was a hyperopic shift, but his blood sugar also hasn't come down significantly.
Not yet, right?
So, right, because he just started treatment. So
I was looking up possible causes of a temporary bilateral hyperopic shift. And some of these we did talk about earlier in the episode. But if we start from the front of the eye and work posteriorly, so if like taking a closer look at the cornea, where there's a possible reduction in the curvature of the cornea, that can induce hyperopia due to some sort of corneal pathology, right? I know Amrit mentioned this before. Addie's tonic pupil can be associated with the hyperopic shift. So it's so important to check pupils if they're equal, round, and if they're briskly reactive. Of course, we talked about cataracts. Usually that causes a myopic shift, but they can occasionally produce hyperopia, especially with anterior cortical changes, right? And then even posterior dislocation of the lens itself can induce hyperopia. And then we just talked about this. We were talking about something like pushing the RPE or retina anteriorly, which can shorten the axial length, like due to an orbital mass. So I know, Alex, that was one of your major concerns at the beginning. That can definitely induce hyperopia. So reviewing OCT and doing an MRI are important, possibly in these kind of specific circumstances. And then also reviewing their medication list, except I couldn't find any medication in any literature that can cause hyperopic shifts. There's a lot that can cause myopic shifts, but do you guys know any that can potentially cause hyperopic shifts?
No.
Yeah. So I couldn't find any medications there. So if anyone knows of particular medications that can cause a hyperopic shift, let us know. And yeah.
Good job for figuring that out, because that literally, I don't know, diabetes was not the first differential on any of our minds. So it was a really good call to do blood work on that one for sure.